To heal properly, bone fractures need certain favorable conditions. When fractures occur, often the bone fragments shift or become displaced. For the bone to heal properly, the fragments must be moved back into place or reduced. Often, a fracture can be reduced by pulling on the limb from the outside or slowly applying pressure directly on the bone. The muscles and other soft tissue pull the bone fragments back into place. After the fracture is reduced, the bone fragments must be kept stable. In other words, the bone fragments should not be able to move past each other. To stabilize fractures, doctors use three common techniques: casting or bracing, external fixation, and internal fixation. Casting or bracing is a non-invasive, that is, non-surgical technique that immobilizes a fracture from outside the body. It is used most often for children because they heal quickly and very little force is needed to hold the fracture stable. For adults, casts and braces are used in very specific situations, like small or hairline fractures, or in challenging anatomical locations, like when the patient wears a sling to stabilize the involved arm after a collarbone fracture. Another fracture repair strategy is external fixation. This technique is minimally invasive, meaning it involves some surgery and anesthesia. External fixation is most commonly used in emergency situations, when the patient has a severe fracture as well as other serious injuries that need to be addressed first, like injuries to their internal organs. A surgeon can apply external fixation to a broken bone very quickly in the emergency room to stabilize the fracture. The technique involves drilling metal pins through the skin into the bone on all sides of the fracture. The pins are then connected to a rod or rods that run outside the body and form a scaffold around the fracture. External fixation is temporary. An obvious reason is that the open wounds caused by the pins in the skin increase the chance of infection. After the patient is medically stable, the external scaffold is removed, and the patient typically undergoes internal fixation surgery, which we will cover next, to permanently repair the fracture. Internal fixation involves surgically implanting a piece of metal in the body with screws to hold the bone fragments together. Internal fixation is the most stable way to treat a fracture and is the preferred technique that surgeons use on most adult patients. Internal fixations are done in two ways. The first option is fracture plating. This surgery involves placing a metal plate against the fractured bone and securing the plate in place with screws. This method involves making a relatively large incision to place the plate and install the screws into the bone. Fracture plating can be performed in many anatomical locations, and it can be used when the bone is broken into multiple small pieces, which is called comminuted. Custom fracture plates are available for nearly every possible fracture location and type. The other option for internal fixation is intramedullary nailing. Intramedullary refers to the medullary canal, the hollow center of the bone shaft that contains bone marrow. In intramedullary nailing, the surgeon removes the bone marrow to place a long nail that contains horizontal holes down the medullary canal. Like the plate, the nail is secured by screws that pass through the bone and the nail. Intramedullary nailing is the preferred surgical technique for long bone fractures, particularly fractures in the bone shaft. Your long bones are your tibia, femur, humerus, radius, and ulna. Compared to fracture plating, the smaller incision for the intramedullary nailing technique can reduce the overall chance of infection and shorten recovery time. Three questions help doctors decide between installing a plate or a nail to fix the bone fragments. First, doctors consider the type of break and the pattern of the fracture fragments. For example, a comminuted fracture, where a bone is broken into many pieces, is best repaired with a plate that can accommodate multiple screws to secure the fragments. A transverse fracture has only one fracture line, which can be repaired with an intramedullary nail. Next, surgeons consider the location of the fracture on the bone. Is the fracture line far enough away from the proximal or distal ends of the fracture? Fractures at the end of a bone often need plating to achieve proper alignment and remain stable, while fractures in the shaft region of long bones can be repaired with intramedullary nailing. Finally, surgeons consider whether the intramedullary canal is safe to access. Can the canal be reached without damaging soft tissues, ligaments, or tendons? If the answer to all three questions is yes, nailing is the best course of treatment. Like engineers, surgeons follow specific guidelines to repair fractures. Generally, these guidelines are: choose the correct size nail or plate to apply to the bone. Install multiple screws on both sides of the fracture to prevent bending and twisting and to increase stabilization. and maximize screw length when possible without harming soft tissues like cartilage and blood vessels. Longer screws are more secure and create a stronger fracture repair. Regardless of the method chosen to fix a fracture, recovery time is typically 6 to 8 weeks. This time frame varies based on the fracture type and location. Unlike skin, broken bones heal without forming scar tissue, but immobilized muscles tend to weaken and wither. To heal properly and regain full function, the patient usually needs rehabilitation, including strengthening exercises, at least for a time.